Great. Hi, my name is Kelly Rath. I'm a GYN oncologist with Ohio Health, and today we're going to talk a little bit about HPV vaccination and give some updates about vaccination guidelines, as well as some outcomes on how we're doing with HPV vaccination. HPV is a non-enveloped double-stranded DNA virus, and there are multiple different types of HPV virus. We know that many of them cause cutaneous infections like common hand and foot warts. We also know that mucosal types of HPV can be associated with high risk or oncogenic strains causing cervical cancers or precancers, anogenital cancers or precancers, oropharyngeal cancers, as well as low-grade cervical disease. We know that low-risk HPV-related disease, most commonly HPV 6 and 11, is associated with genital warts, laryngeal papillomatosis, and low-grade cervical disease. We know HPV is linked with over 90% of cervical and anal cancers, 70% of head and neck cancers, and 60% of penile cancers. When we think about HPV cancers worldwide, over 500,000 cervical cancers occur worldwide related to HPV infection. Next, most commonly, we see anal cancers, head and neck or oropharyngeal cancers, vulvar, penile, and vaginal cancers. So a very large burden of cancer related to HPV infection and potentially preventable with vaccination. When we think about in the United States, we're looking at a little over 47,000 HPV type related cancers and about 37,000 or almost 47,000 of those being likely caused by an HPV infection. And when we think about Ohio, we can see Ohio is a dark blue state. Meaning one of the highest rates of HPV-related cancers in the United States among both men and women. And again, we can see that there's about 1,500 cases of cancer each year attributed to HPV that are potentially preventable with vaccination. And so let's talk a little bit about the HPV vaccine as well as vaccine recommendations. The HPV vaccine is a recombinant L1 capsid proteins that are virus-like particles. They are non-infectious and non-oncogenic and produce higher levels of neutralizing antibody than natural infection alone. When we started our HPV vaccine story in the late 2000s, 2006, 2009, those actually should be flipped with the bivalent first and the quadrivalent second. We had just 16 and 18, those two high-risk strains, and then the quadrivalent vaccine with 4 strains. Today, we just have one vaccine against 9 different strains, so 2 low risk, 6 and 11, and then the rest high risk, 16, 18, 31, 33, 45, 52, and 58. And this vaccine was approved in 2014. So when do we want to vaccinate people? And so the optimal age for vaccination is when our children are young, between age 9 and 11. We know that before age 15, so as long as the vaccination series is started prior to age 15, only 2 doses are needed at 0 and then at 6 to 12 months later. Catch-up vaccination after age 15 is 3 doses. Additionally, patients who are immunocompromised at any age would need the 3-dose series. We want to get those doses in early. On time is considered ages 9 to 12. We used to really focus on 11, and more recently we're focusing on age 9. And so why are we focusing on age 9? It gives us more time to get the series completed by the age of 13. It's been shown to have decreased questions about sexual activity by parents and guardians. It increases vaccination overall, and therefore is going to increase the number of cancers prevented. We see strong immune responses in young patients. It decreases the request because we're not presenting with school vaccines that are required to only get the required vaccines. Several systems, again, have shown this to increase vaccination rates. This is increasing our likelihood of completing the vaccination series before any exposure to HPV is happening, and you'll see why that's important in the coming slides. It decreases the number of shots. At age 11, kids are going to need 3 shots if we do HPV with it, and if we get this done prior, it's decreasing the number of shots that they'll need at each visit. And it's also been shown to be highly acceptable. And so kind of shifting our focus to really start to talk about the HPV vaccine at age 9 versus age 11. And so again, catch up late vaccinations. We should be vaccinating everybody through age 65, or I'm sorry, 26 if they're not previously vaccinated. We know that the vaccine is approved up to age 45. And so the highest risk patients age 27 to 45 can decide to get the vaccination after conversations with their provider. And again, just another slide reminding us that ages 9 through 14 are 2 vaccines, ages 15 through 26 are 3 vaccines, and that schedule is 0, 1 to 2 months later, and 6 months later with a 3 vaccine versus 0, and then 6 to 12 months later with the 2 vaccines. Patients are considered adequately vaccinated if they've had the 2, 4, or 9-valent vaccine, but again, the 9-valent vaccine is the only vaccine that we are giving today. Patients should not get the HPV vaccine if they've had a previous allergic reaction to Gardasil or to yeast. If they have a moderate or severe acute illness, wait until that illness subsides, just like you would with other vaccines. For pregnant patients, we should delay initiation until after delivery. However, pregnant patients that have been given the vaccine prior to finding out that they're pregnant are not at increased risk. There have been no adverse pregnancy outcomes or possible side effects to the developing fetus reported when patients do get the vaccine during pregnancy. So let's talk a little bit about the HPV vaccine safety. This can sometimes be a hot topic with patients as well as providers. We've been collecting data through all of our routine vaccine data safety sources. And so we have over 15 years of HPV vaccine safety data with over 135 million doses given. And there's very robust data in the United States showing that these HPV vaccines are safe. As with all vaccines, like I said, we continue to monitor the safety of these vaccines, and we can assure patients that have concerns about this vaccine that they are safe. Certainly, anybody can have an adverse reaction when they get a vaccination. Just like with all vaccines, there can be redness or swelling at the site. Patients can have fevers, headaches, nausea, muscles or joint pain. Life-threatening allergic reactions can occur after any vaccine, including HPV, but are common. And certainly syncope or related symptoms can happen after any vaccine, including HPV. And so reminding patients, especially those teenagers that are at risk or more commonly for this, remembering to stay seated or lying down during the vaccine and resting for those 15 minutes to prevent those things from happening. Vaccine safety and efficacy data is online and certainly can be found at this CDC website. And so all of the most up-to-date safety as well as efficacy data can be found on the CDC website. And so let's talk a little bit about some of that efficacy data and the impact of the HPV vaccine program. And we'll talk about early outcomes, which are years after starting, and we have great data on this about HPV prevalence as well as genital warts. Mid outcomes, years to decades after starting our vaccine program, showing a decrease in precancers of the cervix, vulva, as well as late outcomes, decades, HPV-associated cancers. And we actually have some of this data that's been published in the last few years that's incredibly exciting. And so since we've implemented our vaccines, we've seen declines in vaccine type infections, vaccine-related vaccine type HPV, genital warts, cervical precancers, as well as recurrent laryngeal papillomatosis in kids. And so when we look at the HPV prevalence rate, and we saw this very quickly, we saw that in both girls between 14 and 19 and people between 20 and 40, a significant decrease in HPV prevalence, vaccine-related HPV prevalence. We saw that in Australia, where they had an incredibly robust vaccination program, a significant decrease in genital warts after the vaccine was implemented. And so you can see the straight line up and down on the screen is implementation of the vaccine. And you can see that in the youngest patients, which is the dark blue line, we see the largest benefit or largest decrease in the HPV-related genital warts after vaccination. When we look at at recurrent respiratory papillomatosis associated with low-risk HPV 6 and 11 with the vaccine introduction in 2006, 2007, we see a significant decrease in both national and state level data of these cases. We see in large studies that preventing CIN2 in patients who have never been exposed, 97 to 100% effective, and about 40% in the overall population, so patients that have both been exposed and unexposed, and similar numbers in vulvar dysplasia. When we look at overall cervical precancer rates over time, we see that they are decreasing, and we see that they decrease the most in our younger patient, the 18 to 20-year-olds, and also decreasing in the 21 to 24-year-olds as those patients are of the ages that they were vaccinated early. So incredibly exciting data. And again, additional data showing decreased anogenital warts, and this is among women and girls, and see that they are decreasing by 67, 54%, as well as decreasing cervical precancers. And so this is systemic reviews and meta-analysis of population-based data. So not necessarily patients that are part of a clinical trial, but just looking at our data of our population and seeing these rates decrease over time. And then a trial looking at HPV vaccination in men who have sex with men, and significant decreases in anal dysplasia. Impact of HPV vaccination on oral HPV infection. Again, so this was just a trial looking at women who received either the HPV vaccination or the hepatitis A vaccine. And you can see a significant decrease in oral HPV infection among those who received the HPV vaccine versus the hepatitis A vaccine, showing a prevention of HPV oral infections, and hopefully that would translate into a decrease in HPV-related head and neck cancers. So what's the data behind age 45? Why did this recommendation come over the last few years? When we looked at the efficacy against precancers in the per protocol population, 88%. In the positive but DNA negative, about 60%, and then in the overall population. So essentially the overall population, about 47% effective. And so in patients, most of us haven't been exposed to all of the different HPV strains. So if we've been exposed to one and then get a vaccine later, we're being protective against different strains and then have a decreased chance of developing these precancers or cancers over time. And so in patients that do have an increased risk of exposure in this age group, certainly vaccination makes sense, and it's a patient and physician discussion. And so I think this was one of the most exciting articles that I've seen published. And so in October of 2020, this article was published in the New England Journal out of Sweden. The registry there showing an incredible decrease in cervical cancer among vaccinated patients in the green line at the bottom versus unvaccinated patients in the yellow or orangish line on top. And we see the largest decrease in patients that are vaccinated under age 17. So when we vaccinated them older, there was still a decrease in cervical cancer, but to really see that very low rate, we need to vaccinate them early, which really is kind of what we were talking about earlier on. We want to get those vaccines in early before people are exposed to HPV at all. And so what is the duration of vaccine protection? Studies suggest that this vaccine is long lasting. There's no evidence that we have seen yet of waning protection, and available evidence indicates protection for at least 12 years, and we continue to monitor this in studies moving forward. So the HPV vaccine is safe. The benefits far outweigh any potential risks. And we find that the safety studies for HPV vaccination are very similar to the meningococcal and Tdap vaccine safety reviews. We know that the vaccine works, preventing early and mid outcomes, as well as most recently our late outcome of cancer, showing an incredible decrease. And we know that the vaccine protection lasts over years with no evidence of waning protection. And so how many cancers might we prevent? Again, it's the same slide that we looked at the beginning, up to almost, as some of these rates increase, 40,000 cases a year, 35,000 cases of cancer each year could be prevented in the United States. So how are we doing with vaccination? You can see here is another chart. Here, Ohio is in the middle blue color, so 60 to 64% vaccination rates, and we have significantly improved over the years that I've given this talk. When I first started giving this talk, we were down in the low 50s, dark blue, and have improved. And so when we look at this and what we kind of benchmark the HPV vaccine data to is the meningococcal and Tdap vaccine. So you can see them in the light blue and the dark blue, and this is national data. And you can see that those are at 80% or above. The orange line is one dose of the HPV vaccine in men and women by age 17. And then the lines below are, you can see females in the dark blue have the highest rate of completion of the vaccine and males have the lowest rate. And you can see that those nationally are right around the mid 50s. And you can see the Ohio data is very similar. A little downtick in vaccines overall with the COVID pandemic, but you can see we've been making significant progress over time since 2016, increasing vaccination rates among our youth. So how do we talk about the HPV vaccine? Data continues to show that a clear and concise recommendation from a healthcare provider increases vaccination rates among children and adults, and is the main reason that parents decide to get a vaccine for their kids. And when we look at patients receiving a recommendation, so in this study, 80% of patients or parents received a vaccine recommendation. And if the vaccine was strongly recommended, 81% went ahead and vaccinated, versus if the vaccine was not recommended, only about 52%, showing that that strong recommendation from their healthcare provider, whether that be a physician, a nurse practitioner, a physician's assistant, a nurse, pharmacist, that recommendation is the most important thing. And again, the top reason for not vaccinating, certainly safety and side effects, but many patients didn't vaccinate their children. Parents didn't vaccinate their children because the vaccine just wasn't recommended. And so again, reminding you, we're focusing on HPV prevention starting at age 9 and starting those discussions early to get that vaccine in and give us the most amount of time to complete the vaccine series. Lots of information on the CDC's website and on the National HPV Vaccine Roundtable, kind of talking about when should we get these vaccines in, and protecting our preteen and teen with vaccines, literature that you can share with patients and family members in your office, and a reminder that on-time vaccination for HPV is 2 doses between ages 9 and 12. If not started prior to 11, and you're talking about it at the preteen vaccine appointment, it's the same way and same day, recommending HPV vaccination in the same way that you recommend the Tdap or the meningococcal vaccine, recommending them as a bundle and not singling out the HPV vaccine by itself, results in increased vaccination rates. And so people ask me in my practice all the time, as a GYN oncologist, I don't get an opportunity to vaccinate people all the time, but I certainly talk to all my patients about it, talk to them about it for themselves if it's appropriate, but then also for their family members and their children. And so people ask me, would you give it to your kids? As soon as they are old enough, they'll get the vaccine. It's only 1.5 years away. When I started doing these talks, my kids were like 2, 1, tiny little babies, and this is them before their first day of first grade. And so both of them will be getting their HPV vaccine at age 9. And so that's all. So just reminding you, the HPV vaccine is cancer prevention. It's really great opportunity for all of us to work to end and prevent all HPV related cancers.